In this lecture, Dr. Jay Wortman will talk about his practical experience in using the low carbohydrate diet for the management of obesity, type 2 diabetes, and insulin resistance.
We have a health system that doesn't care about nutrition and a food system that doesn't care about health. Here's a big reason why. These are pretty much all the brands you're familiar with, and the large conglomerates, there's about 9 or 10 of them that control all those brands. And you can't really see the detail here, but if you did, you would notice that virtually all these products are they're a combination of 3 essential things: grains, sugar, and seed oils. And if you go into the supermarket and you pick up virtually any kind of product off the shelf and you read the label, you will find that most of those things are comprised of those 3 types of foods. And I think that is why we're so sick. I think each one of those things are problematic, and the combination of them together are especially bad for us. I come from the northwest coast of North America. I live in Vancouver, and I like to go fishing. And this is a picture of salmon fishing up the coast off an island called Haida Gwaii. And this is the picture we send home to Mummy about how we catch our salmon. And this is actually what really happened.
At the river mouth, the bears catch only the tastiest, most tender salmon, which is exactly what we at John West want. John West endure the worst to bring you the best.
So I stumbled into low carb. I was one of these people that stumbled over the truth, and I didn't get up and dust myself off and hurry off. I got really interested in it, and at the time I was working in First Nations Inuit Health Branch of Health Canada. That's the part of the federal government health service in Canada that provides health services to the Aboriginal population. And I come from that population. My mother's family are Métis, which is one of the Aboriginal peoples. And I actually developed type 2 diabetes. I have a strong family history. Lots of people in my family have it. And I thought going to medical school and becoming a doctor and being really smart would protect me, but it turns out that didn't work. I developed type 2 diabetes, and at the time that I developed it, I had been out of clinical practice for a while. I'd been working in the government in an administrative job, and I, at that time, didn't feel completely up to date. I'd been well trained and had lots of experience treating diabetes, but felt that I needed a little time to go and basically decide which drug I should be on. There's new drugs on the market. And I knew enough about diabetes to know that certain foods made your blood sugar go high. And I wanted to minimize that effect while I went into the literature and read up. The last thing that occurred to me was to go see a doctor, of course. So what I did was I made a decision from the moment I discovered I had type 2 diabetes that I would not eat carbohydrates. And I knew nothing about, well, I had the standard education a doctor gets on nutrition. Basically, we're taught, go see a nutritionist. We are not taught about nutrition. But I did know enough to know that carbohydrates make my blood sugar go up. So I stopped eating carbohydrates instantly. Bang, just like that. And my wife's a worrier, so I didn't want to mention anything to her. But of course, she noticed fairly quickly that I was sitting at the dinner table eating with her, avoiding carbohydrates. So when I finally confessed that I had diabetes, she went somewhere and pulled out a dusty old copy of the Atkins diet book. And when she had brought that home to lose weight after our first child, I had brushed it off. This is what I had been taught. These diets, yeah, go ahead, they don't work. Give it a try, but good luck. And she brought out the book, dusted it off, and said, "You're on the Atkins diet, dummy." And so I took the book and read it, and sure enough, I was following the Atkins diet. And without any really, up until that point, experience with diet at all. One of the things that happened very quickly was all the signs and symptoms of diabetes that I had been experiencing went away within days. At the same time, my blood sugar normalized and remained normal. I started losing weight. I lost about 1 pound a day, and that went on for about a month. So I became very, very curious about this. This had worked brilliantly. I no longer needed to worry about a medication. I was feeling better. Everything was getting better. And why had I not heard about this before? Never in my medical training or in my practice. And I did some special training in diabetes. Actually, one of the first things I did as a doctor was I was the camp doctor at the Children's Diabetes Camp. Did that for about 4 years. So I knew all about management of diabetes, the diet, and so on. Why had I never been taught that all you had to do was stop eating carbohydrates? So I started looking into the literature, and it was at that time I mentioned earlier that Dr. Westman had published his first article. And we made contact, and then he introduced me to other people like Dr. Steve Finney, who you'll hear from today. And we actually collaborated and did some research together. One of the things that inspired me early on, though, was in my job working with First Nations people, I started talking to people about what's going on in this population, because in that population, like other Indigenous populations, there was a tremendous problem with diabetes, huge problem. I gave talks. I often had opportunities to speak to audiences, and I started telling them my story, that just taking carbohydrates out of my diet fixed my diabetes. And the other interesting part of that was that in the area where I worked, the traditional diet of Aboriginal people was low in carbohydrate. So I started making the argument to them that maybe if you went back to your traditional diet, which is low in carb, you might have the same experience that I've had by reducing carbs. And you have the advantage of knowing that not that long ago, this is how your community, your people ate. And I gave a talk like that, and there was this man in the audience. This picture you see here is a good friend of mine. His name is Jimmy Wilson. He's a First Nations man from the coast of British Columbia. He's well-educated. He's a political leader. And at the time this picture was taken, he had metabolic syndrome and type 2 diabetes. He was a classic example of someone in that population that we see so often. Overweight, metabolically compromised, on medication, and not doing well. He was 48 years old. He'd been using insulin for 17 years. He'd already had a stroke. He was not controlling his blood sugar. He was on a med for his blood pressure. He was not controlling his blood pressure. And he heard me give a talk. And all it took was really interesting, 1 hour talk. And then he went home and he started sending me emails. And he went to his nursing station and got weighed and checked up and so on, and then stopped eating carbohydrates. In his first 2 weeks, he sent me a note, weight loss 17 pounds, normal blood sugar, no insulin. Here's a guy who's been struggling for 17 years, using lots of insulin and a bunch of other medication, not getting his blood sugar under control, suffering the consequences of that. Now, within 2 weeks' time, he's completely off his insulin and he has normal blood sugar. 4 weeks, 31 pounds of weight loss, no blood pressure med, normal blood pressure. 9 weeks, 37 pounds of weight loss, excellent blood pressure, normal blood sugar. 18 weeks, 46 pounds weight loss. He's had his lipids done. His cholesterol is normal. He's on no medication. He's got normal blood pressure, normal blood sugar. I scorched my larynx there out in the sun the other day. Now, I used to show these slides. I do a lot of medical education lectures, and people used to say to me, oh, anybody can do that. 18 weeks is not a long time, and nobody can stick to this diet over the long term. So I got tired of hearing that, and I sent a note to my friend, and he sent me this photo. This is 7 years out. He's lost an additional 50 pounds. As long as he stays off carbohydrates, he has normal metabolic markers, and he requires no medication. He's had a couple relapses where he starts eating carbohydrates and everything starts to go wrong. He gains weight, the blood sugar goes up, everything goes sideways. And then he stops eating carbohydrates and it all corrects and goes back to normal. I had an old-fashioned medical education where we had a lecture on how you diagnose a food intolerance. That's how you diagnose food intolerance. Jimmy has an intolerance to carbohydrates. When he eats carbohydrates, he gets into all kinds of metabolic trouble, and when he stops eating them, those troubles go away. Diabetes is a food intolerance. Metabolic syndrome is a food intolerance. A big proportion of our obesity epidemic is a food intolerance. A whole bunch of other things connected to this are intolerance as well. Intolerance to carbohydrate. So we collaborated, Westman, Finney, Mary Vernon, a couple of other people collaborated, and we went into a small First Nations community and we said, hey, you should try your traditional diet and we'll do a study and see what happens. And we followed people for about a year and watched as their diabetes got better, they lost weight, and everything improved. The Canadian Broadcasting Corporation was intrigued by this and made a documentary film about it. It was broadcast a few times in Canada, My Big Fat Diet, and it's actually it's available on YouTube. I don't think the producers like me telling you that, but you can find it on YouTube, and I would encourage you to watch it. It's a really nice story of this little community and these individuals who turn their health problems around simply by avoiding carbohydrates. Now, I look at our chronic disease epidemics as a continuum. We've got big problems with overweight and obesity, metabolic syndrome, type 2 diabetes, heart disease, stroke, cardiovascular disease. And what I think is going on is we actually have one epidemic of which all these things are different manifestations. And the epidemic that I'm talking about is insulin resistance. We have an epidemic of insulin resistance. And what I just told you about carb intolerance, another way of looking at insulin resistance is carbohydrate intolerance. The underpinning of all these conditions is insulin resistance. The title of this slide is a simplified version of insulin action. There will be a test at the end. Famous diabetologist in Australia, Paul Zimmet, published this a few years ago. His point here is that type 2 diabetes is the tip of the iceberg, essentially saying what I'm saying here. And in this case, the iceberg is metabolic syndrome. Metabolic syndrome is, most people think of that as pre-diabetes. Your insulin resistance starts to develop and is manifested as high insulin levels. You gain weight around the middle. Your cholesterol numbers start to get wonky. You get hypertension. So if you have a combination of 3 or more of those things, you have metabolic syndrome, and that tells us that you're on the path to develop type 2 diabetes or cardiovascular disease or both. We also know that a whole bunch of other things cluster around metabolic syndrome. Fatty liver, small dense LDL, that's the bad cholesterol, oxidative stress, think of that as free radicals, inflammation, hypercoagulability, that's why a lot of people are taking a little bit of aspirin, polycystic ovary syndrome, problem for young women, acid reflux, sleep apnea, asthma, osteoporosis, depression, Alzheimer's, cancers. This list constantly grows longer. There are so many things now, so many chronic conditions that are actually associated with insulin resistance. It's quite remarkable. When metabolic syndrome was first described, it was back in the 90s. Gerald Reaven, American researcher, came up with this concept. And at the time he described it, well, he called it Syndrome X. That sounds pretty sinister. But we now call it metabolic syndrome. But he said the basic defect is resistance to insulin-mediated glucose disposal. In other words, insulin resistance. And he goes on to say here that if dietary carbohydrate is increased in an isocaloric diet, additional insulin must be secreted to maintain glucose homeostasis. What he's saying is when you develop insulin resistance, your body produces more insulin to control your blood sugar, to keep your blood sugar in the normal range. So insulin resistance goes hand in hand with high insulin, hyperinsulinemia. So remember that. Here's a chart that shows what we call the natural history of diabetes. And what you see there is along the bottom, those are years. Those numbers represent years. And that 0 year is the point at which a diagnosis of diabetes is made. And the point here is that if you go back in time, in this case 12 years, and you looked really hard, you would see the beginning signs of insulin resistance, that it starts out slowly and quietly and indolently and you don't really notice it. But one of the things that starts to happen as soon as you develop insulin resistance, represented by this dotted line, is your ability to produce insulin starts to decline. You're in a state of hyperinsulinemia, your pancreas is pumping out excess insulin to compensate for your resistance, and it basically is burning itself out. And that decline starts to go down. That beta cell function goes down to the point where you can no longer control your blood sugar. And that's when we diagnose it. We find you've got a high blood sugar, and then we figure out that this has been going on for a long time. Those yellow dots are the therapies, the drugs, the insulin, and what this represents is that when we treat those with those things, we're not actually treating the cause, we're treating the symptoms because the underlying disease process continues. And we do use a lot of drugs. This is a chart with the classes of drugs, not just individual drugs, that are used to treat metabolic syndrome type 2 diabetes. There's, I think, about 25 classes of drugs here, multiple drugs in some of those classes. A lot of money involved. Now, think about obesity as the leading edge of this epidemic of insulin resistance. And in the US, we've got good data on what's gone on over the last 30 or 40 years with their obesity epidemic. You've probably seen these type of slides. If you saw Super Size Me, they showed them in that documentary. I'm not going to use them now. All of them. This is one of the more recent ones. And what it is showing is that there's this huge epidemic of obesity on the North American continent. It's now a worldwide problem, of course, and that it's something that happened in recent memory. Another way of looking at it is this line graph that shows that obesity rates have gone very high in the last few years, and there is an inflection point there in the late 1970s where something obviously happened to cause this epidemic to take off. And then in this chart, you see a similar shape of the curve of type 2 diabetes in the US. And the interesting thing here is the time frame. This epidemic takes off about 12 years after the obesity epidemic. So it fits nicely with that earlier slide showing the indolent 12-year period of insulin resistance before you develop type 2 diabetes. Now, why does this happen? I mean, we saw something happen over a relatively short period of time. We know when it started, so we should be able to figure out why it happened, what happened back there that changed. And of course, we've got all the brilliant minds in the world working on this, and they've come up with the answer. People eat too much and they exercise too little, and that makes them fat. And being fat leads to metabolic syndrome, type 2 diabetes, heart disease, or both. And everybody agrees. This is the WHO. Overweight is an energy imbalance. The Center for Disease Control, weight management is all about balance. United Kingdom, simple imbalance between energy and energy out. Everybody agrees and have agreed for many years. And it's based on that understanding of the epidemic that our prevention activities have been designed and implemented. So we've told people to exercise more, watch their portion size, exercise some more, stay away from the junk food, and exercise some more. And during that time, we've gone from there to there to there. It really hasn't worked very well. It's pretty much summed up by this T-shirt. Now, in any other endeavor, when you've been trying something and doing everything you think you can do to make it work for a few decades, let's say shooting a rocket to the moon, and every time you shoot your rocket, it blows up and crashes in the ocean. At some point, would you not go back to your fundamental paradigms and question whether, are we actually doing this right? And maybe try something different? I think the answer is yes. We wouldn't be where we are with spaceships flying out into the cosmos and computers and all the other things we've come to take for granted. Airplanes, thank goodness. But in nutritional science, we don't do that. It's absolutely remarkable to me that we do not admit that our current paradigm is a failure and go back to basics and ask fundamental questions. Did we get this right? For some reason, we just don't do it. So let's look at exercise. I mean, it makes so much sense that if you're trying to lose weight, which is just excess energy that you've stored up, that if you burn off more of it, that you should be able to shed some weight. As it turns out, the literature is pretty clear now. Exercise is a really poor strategy for weight loss. This is summed up in an article by Westertip just 5 years ago, in which the author says, an exercise-induced increase in energy requirement is typically compensated by an increased energy intake. I'll translate that scientific language for you. When you exercise, you get hungry and eat more. Okay? This is brilliant Nobel Prize-winning science here. And then it gets better. Overeating does not affect physical activity, while undereating decreases habitual or voluntary physical activity. In other words, overeating doesn't make you exercise more. And if you don't eat enough, you exercise less. So they pretty well figured out here that why exercise doesn't work. And then later in the same article, the author says, there are two ways in which the general population trends towards increasing body weight can be reversed: reduce intake or increase physical activity. WTF? That's what you call cognitive dissonance, okay? Holding two contrary and opposing ideas together at the same time. And you see this all the time. Okay, if it's not exercise fat, it's dietary fat. You eat fat, you get fat. Everybody knows that. It makes so much sense. There's 9 calories in a gram of fat versus only 4 in a gram of carbohydrate or protein. So if you're trying to shed weight, you got to stop eating fat. Walter Willett at Harvard did a meta-analysis. This is a few years ago, but nothing's changed. He gathered up a bunch of studies all around the world, China, Europe, North America, and pooled the data and analyzed it, comparing what people ate at a population level in terms of fat, how much fat people consumed per capita in a country, and what their obesity rate was. And he found no relationship between the amount of fat people ate and how fat they were, except for the European women. They were actually skinnier if they ate more fat. All that brie and butter and those slender French women. Life's not fair, right? And then he says, he concludes, diets high in fat are not the primary cause of the high prevalence of excess body fat in our society, nor are reductions in dietary fat a solution. Okay, that makes sense. And then in the same paper, he goes on to say, the solution is exercise. SMH. Now, this is American nutritional data. This is per capita consumption of certain macronutrients. This is grams of fat and saturated fat. And that red arrow is where the obesity epidemic takes off. If dietary fat or dietary saturated fat had an influence on that epidemic, it sure does not look like it from this graph. There is no change in that consumption here. Now let's talk about saturated fat, because when we talk about fat, we're talking about calories and weight, but saturated fat has a special problem. It's that fat that clogs your arteries, the way hot bacon grease clogs the cold kitchen drain. You eat that bacon fat, it gets stuck in your arteries, right? Causes heart attack. Well, it turns out that's not true. This is a study that was published 5 years ago now, which kind of set the cat amongst the pigeons. These are credible researchers in the States. What they did was they pulled together 21 prospective cohort studies, big observational studies, that ran from 5 years to 23 years, so big, powerful studies. Total number of people involved, 350,000. So when they pooled all that data and reanalyzed it, what they were looking at was the relationship of saturated fat consumption and any form of heart disease, arterial disease, stroke, heart attack. And they could find no relationship. Saturated fat was not the cause of heart disease. Now, that's observational data, and any good scientist will tell you that you can't draw conclusions from observational data. It's one of the reasons we get so many of our nutritional recommendations wrong, because in nutritional science, we always do this. You do an observational study, and then you leap over the next important step, which is to do a randomized controlled trial. Observational studies generate hypotheses. You find associations. Something happens and something else happens together. Let's see if one of them causes the other. You do a randomized controlled trial to figure it out. In nutritional science, because those trials are hard to do and expensive and they take a lot of time, and we're in a hurry to save you, save your heart and your weight, we leap over that step and we make nutritional recommendations based on observational data. And this is why we get it wrong so much of the time and why the public gets so confused. Because one day they read this is bad and the next day they read it's okay, and back and forth and on it goes. But in this case, we're very fortunate because we do have the randomized control trial. The Women's Health Initiative was essentially the moonshot of nutritional studies. It's, I think, the biggest randomized control trial that's ever been done and probably ever will be done, because the people that believe that fat is bad had marshaled all their forces and all the money they could get. It was over $500 million to do this study to prove once and for all that fat was the problem. And after over 8 years, with about 50,000 women that were randomized and one group ate low fat, they found that there was no difference. There was no difference in weight, cardiovascular disease, stroke, breast cancer, colorectal cancer, everything, nothing changed. And by the way, they told us when that all happened, ignore these results, keep avoiding fat. One of the authors of the epidemiological study, Ron Krauss, is a lipidologist, a scientist that practices in San Francisco. And he's one of the leaders in identifying small, dense LDL as the culprit when it comes to cardiovascular disease. You know that LDL is the bad cholesterol. It turns out that not all of it's bad, that it depends on the particle size, and the small, dense particles are the bad particles. And what Krauss was trying to figure out is what causes small, dense LDL. And in this chart, what he's got here is a diet study, and he's got 4 different fractions of LDL. On the left side is the big healthy LDL particle size, and on the right is the small dense, and in between are the intermediate ones. And in the first group here, he fed people 54% carbohydrates. That's a pretty standard diet, and that's the baseline. Then he reduced the carbohydrates down to 39%, not a big reduction, but he got a significant improvement in the profile of the LDL particle size. Then he went down to 26%. That's only half. That's not a low-carb diet by my definition, but a significant enough reduction to give a huge improvement in the LDL particle size. And then he went one step further, and he swapped out the so-called healthy fats, and he fed these people the evil saturated, the heart-clogging saturated fat. And what he found was that there was an even greater improvement in the LDL particle size profile. So not only was saturated fat not causing the small, dense, atherogenic LDL, it was part of the solution to having a healthy LDL. His reward for that is he finds it very difficult to get funded now. Protein, we have 3 macronutrients: carbohydrate, protein, and fat. We've already shown you fat doesn't cause these problems. Could protein cause these problems? I don't think so. Nobody's eaten more protein than they've eaten in the past. Let's look at carbohydrate. Here, carbohydrate actually has gone up. And it's gone up around the time that the epidemics started. And it probably went up because that was when the first food guide was published, at almost precisely the same time the epidemic started to take off. And the first food guide came out of the McGovern Commission, and it recommended that people cut fat and increase their consumption of healthy whole grains and other types of carbohydrate. So here we are with our paradigm: eating too much, exercising too little makes you fat. Sorry to show you this, but these are my before and after pictures. That's how we explain these two gentlemen. The wider man ate more and exercised less, and therefore stored extra energy. And the other guy did everything right and didn't store extra energy. Does eating too much, exercising too little make you tall? Which one of these guys eats more? You think I'm asking a trick question, right? The big guy eats more. Is that why he's big? No. He's big because there's a hormonal dysfunction. And the flip side with the little guy. He's not small because he didn't eat. He doesn't eat because he's so small, and he's so small because he has a hormonal problem. Maybe there's a different paradigm. Maybe there's a paradigm based on hormones when we look at why people are wider versus narrower. Let's talk about that. Let's talk about insulin. You've heard about insulin. Dr. Westman talked about insulin. Dr. Westman also told you that when you have a normal blood sugar, at any given time in your blood, in your entire blood supply, there is one level teaspoon, this is a heaping teaspoon, one level teaspoon of glucose. That's all the sugar you have in your blood when you have a normal blood glucose. Now, think about that for a minute. If you have a quarter teaspoon excess in your blood, that's a tiny amount. That will harm you over time, might even kill you. That's what happens with diabetics. Their blood sugar is too high, and it causes serious downstream problems. So your body knows this, that blood sugar within the normal range is fine, outside of the normal range is toxic, harmful, poisonous. So your body goes to extraordinary lengths to keep that blood sugar in the normal range. What do? We follow the food guide and we fill up our bellies with heaping teaspoons, many heaping teaspoons of easily digested carbohydrate, which rapidly floods into the bloodstream and overpowers that one little teaspoon with multiple teaspoons of glucose, and puts our body in a state of metabolic emergency where it's scrambling to keep that blood sugar level down in the non-toxic range because we load ourselves up in a very toxic way. So insulin is the actor. Insulin is secreted in large quantities to do this, and it does a bunch of different things. First thing it does is it pushes other fuels out of the way and prioritizes glucose to be burned because you've got to get rid of it. That's one way of getting rid of it, is burning it off. So you push everything else out of the way. The preferred fuel, I think, is actually fat, but we can't allow that to happen. So insulin pushes it out of the way so the glucose can be burned off first. And the brilliant minds in nutritional science make this observation. Oh, all these potential fuels are there and the cells, they're burning glucose first. That must mean that they like glucose. And we should encourage people to eat a high-carb diet because glucose seems to be the preferred fuel. When in fact, the body's desperately trying to get rid of it because it's toxic. In the liver, the effect of insulin is for the liver to turn the glucose into fat. And the liver does this, and under increasing amounts of insulin and increasing amounts of glucose, which is what happens when you get into insulin resistance, the fat production exceeds the ability of the liver to export it, and you develop fatty liver. The fat flows into the bloodstream in the small dense LDL particles, the VLDL particles, and travels in the bloodstream. At the surface of the fat cell, in the presence of insulin, the fat goes into the fat cell and can't get out. Insulin wants to store it out of the way so it doesn't get in the way of burning off glucose. So all this stuff goes on because your body's trying to get rid of that carbohydrate load that you just ate when you had that pasta dinner with some focaccia bread and a tiramisu for dessert. Now, when you develop insulin resistance, your body requires more insulin to make all these things happen. And you get into this vicious cycle of increasing insulin resistance, increasing insulin, and accelerating these metabolic dysfunctional problems that are starting to develop. Now, the other hormone that's involved here is leptin. Leptin is a more recently discovered hormone, and one of the prime purposes of leptin is it's a messenger that goes from your fat tissue to your brain, essentially to tell you to stop eating. When your fat tissue is expanding, it sends a big leptin signal to the brain telling you to turn off the tap. You know, the tub is overflowing, you can turn off the tap. Classic feedback. Now, as I just explained, if you've got insulin resistance and you've got high levels of insulin, you're getting pretty good at storing fat. Your fat tissue is expanding. We would expect that that would send a powerful leptin signal to the brain to tell you to stop eating. You ask anybody with these conditions, and they tell you they're always hungry. They have a very hard time not eating all the time. So something happens here that causes that. And the famous Dr. Lustig, the guy who has the YouTube video, The Bitter Truth About Sugar, he's done work on this. He's done research on leptin, and he's come up with this concept that what happened here is that the big leptin signal that's going to the brain actually gets intercepted and cut off by insulin. That insulin is a leptin antagonist. So that high level of insulin is causing all these problems, including the weight gain. Sending that big signal of leptin to the brain, that same insulin actually heads off that signal and the brain doesn't receive the message. And we know from all kinds of animal research that when there is no leptin signal received by the brain, the interpretation of that is that you are starving. And animals that are starving all do the same thing. They seek food and they conserve energy. So that overweight person with metabolic syndrome, prediabetes, sitting on the sofa, watching the soaps all day, the only exercise is the short trip to the kitchen and back, is actually doing what his survival messaging is telling him to do. Conserve energy, eat as much as you can. It's a survival message from your primitive brain. And what's our prescription? We tell you, get your sorry butt off the sofa, go jogging, and stay away from the fridge. So some people can use tremendous effort of will to overpower that very strong internal message telling you to do the exact opposite. But most people fail. And I think that's why our approach to the obesity and epidemic and all the downstream consequences has been a failure. We've used the wrong paradigm, and therefore we had the wrong prescription. So we got part of this right. Increased calories, decreased energy has a relationship to being fat. We got the arrow wrong. Being fat causes you to do these things, and the reason you're fat is that metabolic dysregulation, the disruption of leptin, the hyperinsulinemia, and the thing that is driving that is the carbohydrate foods in your diet. So if this paradigm is correct, we should be able to fix it by targeting at the starting point the carbohydrate foods in the diet. And that's how a low-carb diet works. So what does the literature tell us? Well, here's a nice, this was a series of controlled trials done by a group in Minnesota, and they're very smart. It's very hard to study low-carb diet. Nobody will fund low-carb diet studies. So they invented a low-bag diet, low biologically available glucose. Wink, wink. That got by them. They got funded to do these studies. And what they have here are different low-carb diets, and one of the unique things they did was when you go on a low-carb diet, people lose weight. They designed these diets so people would not lose weight, so that you could figure out what was the effect of just lowering carbs apart from weight loss. Because if you lose weight for any reason, you'll fix these problems. They will get better. What they're trying to figure out here is what happens when you don't lose weight. How much of this can we attribute to reducing carbs? And what they're looking at here is the hemoglobin A1C, which is the long-range blood sugar test. And they find that when they drop the carbs to 40%, 30%, 20%, they get bigger and bigger improvements in the hemoglobin A1C, the blood sugar control, without weight loss. They compare their results to the results of the common medications used for weight loss. Look at how much better the diet does than the medications. Here's a study. Dr. Westman was involved in one of the studies here. These are actually two studies. The first bars the ones on the far left, the first 2 bars are the results of comparing a low GI diet, a low glycemic index diet, to a standard diabetic diet. And then what you see across the board here with weight, hemoglobin A1C, glucose, lipids, cholesterols, everything is better if you go low GI. In other words, reduce the amount of refined carbohydrates, use whole grains, and so on. And this was published by Jenkins in Toronto, one of our famous Canadian nutritionists who invented the GI idea. Then this troublemaker from Durham, North Carolina comes along, and he compares low GI to low carb. And that's the second 2 bars as you go to the right. And in every instance, the low carb blows the low GI out of the water. Now, these were published in the same year. The Canadian Diabetes Association just put out their guidelines. They invited me to come to their big meeting. And I put this chart up and I said, in your guidelines, you recommend a low GI diet based on one study by Jenkins, yet you ignore another study by Westman published in the same year showing that there's an even better diet. And they're silent on low carb diet, as are most diabetes recommendations around the world. And they didn't invite me back to the next meeting. So when you do a good study using a low-carb diet, and there's a lot of bad studies out there, but when you find the good ones, and they're usually done by people that are experienced and understand the physiology of low-carb diets and don't have an inherent bias against them, we find that people lose a lot of weight, they correct their insulin and leptin resistance, they normalize their blood sugar, blood pressure, cholesterol, they reduce inflammation. All the things that happened to my friend Jimmy Wilson. A bunch of other conditions are showing promise. People are using this type of diet to treat things like Crohn's disease, hemochromatosis, migraine. Milroy syndrome is a congenital edema problem, schizophrenia. Eric published a case study on schizophrenia recently, anxiety disorder, Alzheimer's, brain cancer, traumatic brain injury. The list is just growing and growing where people are exploring the benefits of this type of diet. Now, these are my children. I want to talk a little bit about children and low-carb diet. It's not something we've talked about much in the medical conference, and I thought it would be appropriate to talk about it here, because in my family, after that, my epiphany 12 and a half years ago, my family has been a low-carb family since then. And my son, this is a picture of my son when he was 2. And this picture was taken about 3 or 4 months before I discovered I had diabetes. We were traipsing around Italy there. And he has no idea in this picture that his world is about to change. He has developed a sweet tooth like children have, and he was allowed juice, he was allowed cookies. We thought oatmeal for breakfast was a good idea, and so on and so forth. He might have some anticipation in this picture that life is changing. And it wasn't easy with him, because even at the age of 2, he had preferences in his diet. They learned that quite early. And I remember he had a particular, my wife initially wasn't too keen on it either, and particularly when it came to changing my son's diet. And I remember we had a spirited discussion, we shall say, about juice. And I insisted that he should not be getting juice, fruit juice. And then I went off traveling. I had a job where I traveled a lot at the time, and I phoned home. And my wife said, oh boy, there was a big dust up when I didn't give Alex his juice this morning. She said, I asked him, do you understand why you're not supposed to have juice? And he said, yep, it's full up with sugar and it makes Daddy mad. Another time, he had, we used to give him these oatmeal cookies because oatmeal's healthy, right? And we thought, that's a healthy cookie. And the first time he ever had them was at his grandmother's house. And so he always called them Grandma's cookies. And one day, and we, of course, read labels and, oh my God, it's all sugar. So those are gone. And my wife was running around doing some errands one day. He was in the car seat, in the car, strapped in. She ran in somewhere, came out, drove off. And as she was driving away, he said, when you were gone, I said, frickin' fuck. And she said, why in the world would you say that? He said, frickin' fat grandma's cookies have sugar in them. But he's made the adjustment, you know, and he's quite good about it. We have no sugar in the house. We prepare our kids' foods. There's very little packaged food. He's a good kid. Here we are fishing in the mountains. And then his life changed dramatically with the birth of our daughter when he was 9 years old. I'm going to show you, he's a good skier. This is where I should be right now, by the way. I'm not whinging. I like it here. But I'll just give you a little taste of what it's like. And there's my son in the blue jacket flying down Whistler Mountain at the age of, he's 14 now. And he likes nothing better than kicking his old man's butt on the ski hill. This just goes on and on. There's no crash at the end. Yeah. So my daughter came along. And she, unlike my son, is a product of a low-carb gestation. So my wife stayed on the diet during the pregnancy. But the only thing we noticed that was different was she didn't get any morning sickness. And I know that can happen anyway, so it's hard to say had anything to do with the diet. We delivered a very healthy little daughter who turns out to be very bright. She's trading stocks online there. She was breastfed at the beginning, of course, and then we transitioned her to solid foods, and we made everything ourselves, and we kept the sugar and starch out. So she had pureed vegetables made with olive oil and butter and cheeses and meat sauces that went through the food processor. She ate a variety of what I consider very healthy foods, lots of vegetables, meats, dairy, and no starch and sugar. At 17 months, she decided she wanted to start downhill skiing. I think she was inspired by her brother. She wasn't even talking at this point, but she made it clear to us that she wanted to go skiing when we went skiing. I don't think I've seen a child on the mountain at that age, 17 months. She's barely just walking and not talking at this point. I spent a whole season with a backpack with bottles and diapers. And it's amazing how quickly she developed the stamina to do this sport. This is at 28 months. This is her. She can talk now, and her brother's over there, and her mother's behind that woman. They're talking, and she's saying, let's go, let's go, let's go. She wants to go. So this is the season when she was 2 years old. So she's 28 months here, 28 months. And she loves skiing. And my job that year was to hang on to the tether to make sure she doesn't get away. And we ski all over the mountain that year. And she basically taught herself how to ski. 28 months. That's my wife. And she's gone. And that's the men's downhill race course there. Fortunately, she veered off to the right there, and and you know, I don't think she even noticed that I'd let go. She was not at all traumatized by that, and my wife was when she saw the video later that day. And this is how she skis now. She's 5 years old. She's a very accomplished skier, and she's got incredible stamina, something I attribute to her diet, obviously. This is at the top of Whistler Mountain.
Watch out! Watch out! Oh,
Now, there is no
fuck's sake,
crash
man.
in this one.
Look where you're going.
She has incredible stamina. There's a run on Whistler Mountain. She can ski all day like this on a minimal amount of food. One day last year, at the end of the season, she ate a boiled egg, a small tomato with some mayo, and she ate about 3/4 of that for breakfast, and we skied all day like this. She ate a little, I didn't approve, she ate a little bag of chips at lunch and a small sugar-free chocolate, skied the rest of the day, and at the end of the day, at Whistler, there's a run that goes from the very top to the bottom. It's 7 kilometers long, and she insisted on skiing that as the last run. And I begged her not to because I thought I'd have to carry her. And she skied that whole run virtually nonstop. So this little child on a low-carb ketogenic diet has amazing strength and stamina. It's just remarkable to me. And she's smart. She's in a very enriched school where they teach language. This is her at 4 years old, singing, oops. This is her at 4 years old, singing in Mandarin. She's learned French and Mandarin in her kindergarten school. I ran into her Mandarin teacher recently, and she just said, "Your daughter is scary smart. She learns everything." So I could go on bragging about my kids on and on, but the point I'm making is I'm often contacted by people who say, "I can't find anything on low-carb ketogenic diet for children or for pregnant women." And this is N of 1. But what a wonderful N of 1 it's been. When my wife got pregnant, I did look for evidence anywhere that this could be harmful. And I couldn't find anything that caused me any concern. And I looked at it from this perspective. From the fetus's point of view, what's going to be different? No big surges of insulin or glucose. Okay? No exposure to fructose. But other than that, you're going to have a normal blood sugar, you're going to have lots of good nutrients, and ketones. And the more we learn about ketones, the more we're discovering that they're actually very beneficial for a whole bunch of different things. So one of our speakers earlier this week talked about babies in utero being marinated in insulin. That is a huge problem because we have this epidemic of metabolic syndrome of insulin resistance out there. We have many, many young women with high levels of insulin marinating their fetuses in insulin, and that is not a good thing. Now, I thought I would finish up by just showing you, a lot of times when I speak to audiences, particularly non-medical audiences, they say, "Well, what do you eat?" Here's what I eat. This is my breakfast. I make a frittata once a week. I'm lazy, so I make a big frittata once a week. Eggs, cream, bacon, mushroom, a little bit of onion, cheese. I like some chipotle pepper in there to spice it up. You make it like a big omelet on the stovetop, and then you grill it under the broiler to make it look like a pizza. I slice it up, put it in the fridge, and you can microwave it, take it on with you on the go. Cup of tea, a little bit of tomato and mayo. I never get bored having breakfast. Lunch. I'm even lazier for lunch. I make it once a month. I make a great big pot of beanless chili. It's got ground pork, ground beef, Italian sausage, real Italian tomato, a bit of onion, lots of celery, and a ton of spices. And it is so good. I freeze it in containers, take it with me for lunch to the office or wherever I am. Never get bored with it. Cup of black tea. Dinner. This is a little bocconcini on some rocket with a little steak. Little glass of dry red wine, that's allowed. Here's a piece of halibut from up north the coast. Some roasted cauliflower with olive oil and coarse salt. A little bit of anise. A little glass of white wine. I make my own low-carb barbecue sauce, so I do ribs. And that salad has a little bit of blueberry in it. Don't do that very often, but blueberry, feta, pecans, and a balsamic vinaigrette. Delicious. Goes well with the barbecued ribs. Beef on a skewer, and those are fake mashed potatoes. A lot of our guests don't know they're fake. It's made with cauliflower, mushroom, onion, cream, salt and pepper, olive oil, butter. Put through the blender. It's delicious. That salmon you saw in the first picture, grill it on the barbecue, have it with some cream spinach. That's some roasted chicken with my barbecue sauce done on the grill in a salad. My son photobombing because he thinks his dad's a geek. That's some filet of sole with salad. And you don't. And when it comes to the kids and their birthday parties and so on, I make a low-carb chocolate cake. This is made with almond meal, butter, eggs, a bit of Splenda, and then I make whipping cream for the dressing, and then I chill it all in the freezer, and it's delicious. So my point here, and I could go on and on about the food, is that it's not an abstemious diet. You eat wonderful, wholesome food, very satisfying food, and it can be an adventure. Starting out and figuring out how to eat. There is a recipe book I highly recommend, The Real Meal Revolution. My wife actually has a copy of that. It's hard to get in Canada, but we got one, and it's a wonderful recipe book. So why, if this is so brilliant and so wonderful and fixes all these health problems, why has this not been embraced? I know from my own experience, and my colleagues will all tell you, and I know from what I've heard about Dr. Noak's experience here, that there's a tremendous entrenched view that this is a bad thing, it should not be considered, and there's lots of pushback. Well, there's three reasons. One is what I call lipophobia, fear of fat, and that's been deeply ingrained in us over the years. This is a Time magazine with Ansel Keys, who started the ball rolling with his studies on fat, 7-country studies, who made the statement that fat caused heart disease and stuck to that for quite a while. And this was Time magazine, 1961. He's referring to dietary fat, saying, people should know the facts. Then if they want to eat themselves to death, let them. In other words, eating fat was going to kill you. And that was reinforced in 1984 with this Time magazine again about cholesterol. It was a big study on cholesterol, and by this point we knew that cholesterol really didn't matter, the cholesterol you ate, but nevertheless, cholesterol, and now the bad news. And this is about avoiding fat and cholesterol in your diet. Cholesterol is proved deadly, and our diet may never be the same. So that's been very deeply entrenched. The second influence is calories in, calories out. This is the idea that we talked about earlier, that it's all about calories. Doesn't matter where the calories come from, really. It's just how many calories you have. Here's a map of the human metabolism. Okay? If you believe calories in, calories out, you have to believe that everything there is unimportant. Does that make any sense to you, even if you're not a medic or a scientist? I hope not. And the third factor is herd behavior. Doctors, and I speak for many of my colleagues, we're explicitly taught to stay in the middle of the herd. It's safe there. If you're in the middle of the herd and doing what everybody else is doing around you, you're not going to get into trouble. I was explicitly taught, don't be the first one to use a new therapy and don't be the last one. Stay in the middle. That's where it's safe, okay? Well, people know how to manipulate the herd. The herd has leaders. We call them thought leaders, opinion leaders. We have guideline committees that tell the herd what to do with different diseases and different medications. And people have figured out how to capture those leaders of the herd and steer them to their own benefit. And the whole herd, because we're herd animals, we follow. So we have guideline committees on diabetes, we have guideline committees on statin drugs, and so on, who are profoundly influenced by the industries out there that have a vested interest in these things. These are buffalo hunters who learned that if they could identify the leader buffalo and shoot that one, the herd would not run away. And they could sit in one spot and slaughter a whole herd for that reason. So I think this is going to be a bottom-up revolution, not a top-down one. And this popped up on my Facebook page just a couple days ago. Conducted my own diabetes research study yesterday and today. Yesterday, ate oatmeal and yogurt for breakfast. Blood sugar at 210, 2 hours later. Meat chili burrito for lunch. Blood sugar 190, 2 hours later. Ravioli for dinner with veggies. Blood sugar 180, 2 hours later. Those are all very high. 180 is essentially 100 in your units. Ravenous all day. Today, butter in my coffee, 4 sausage, 2 hard-boiled eggs, blood sugar 83. That's like 60. Or less. 6, sorry. 2 hours later, 66. Late meal at 3 p.m. When you eat this way, you're not hungry. So this person didn't have lunch until 3 p.m. Grass-fed ribeye, asparagus, lots of butter, blood sugar 86. So 6. 2 hours later, less than 6. Not really hungry. Diabetes research complete. Need I say more? These are some of the books that are good. Why We Get Fat by Gary Taubes, The New Atkins by Westman, Finney, and Volek. Finney and Volek have a good diet book. I use this one in my practice a lot. I like Wheat Belly. There's a new Wheat Belly, Grain Brain. The Big Fat Surprise, I really recommend that one by Nina Teich-Holtz, just came out a few months ago. Tells the story of how we got it wrong. I apologize to Dr. Noakes for not having a photograph of his book, The Real Meal Revolution, but I'm sure you all know about it. It's a bestseller here. And then I do take comfort in seeing media starting to focus on this, and we're seeing many more mainstream media stories now that are getting it and reflecting the new studies in the new direction, which I think is all part of a groundswell bottom-up improvement. Here's an example of media. Eskimo tribe on Mars. They live to 140 on all blubber diet. This doctor is saying a high-carb diet I put you on 20 years ago gave you diabetes, high blood pressure, and heart disease. Oops. And this doctor is saying, you went on Atkins and lost 90 pounds, lowered your cholesterol, cured your high blood pressure, and now you're walking 5 miles a day. But I'm warning you, a low-carb diet is bad for your health. Thank you very much.